Hi everyone, this is Dr. Sandeep MB, anesthesiologist, District Hospital Himsaveri. Today I will be speaking on topic anaphylaxis. So what do you mean by anaphylaxis? Anaphylaxis, it's a severe life-threatening generalized or systemic hypersensitivity or allergic reaction that is of rapid onset and involves multiple systems, especially airway, breathing and circulation. So keep it simple. Who defines it as? WHO defines anaphylaxis as anaphylaxis is serious allergic reaction that is rapid in onset and may cause death. So all anaphylaxis is a severe allergic reaction, but not all allergic reactions are anaphylaxis. So the difference between allergy and anaphylaxis. So allergy is a very mild or local reaction. So which usually involves only one system, skin or mucosa. So and the symptoms will be very mild, and it is of gradual onset, and it causes mild symptoms like itching, localized urticaria, mild swelling and sneezing. So it is not life threatening and can be treated with antihistamines and some steroids, and it is mediated by IgE, and examples are mild rash after amoxicillin. So what is anaphylaxis? It's a severe systemic reaction where it is severe, life-threatening and a systemic allergic reaction involving airway, breathing and circulation, which is of rapid onset, and it involves multiple systems: skin, respiratory, cardiovascular and gastrointestinal system. So generally the symptoms will be generalized urticaria, angioedema, bronchospasm, hypotension, shock and cardiovascular collapse. So absolutely it is life threatening and it can cause death also. So the treatment is the first line is IM adrenaline, first line, and followed by fluids, oxygen, airway management, as well as antihistaminics and steroids. So usually IG mediated, but it can be non-IG mediated also. So example are collapse and wheeze after IV antibiotic, latex exposure or blood products transfusion. So common agents in hospital which can cause anaphylaxis are antibiotics, blood products, muscle relaxants and induction agents in the operation theatre, and some painkillers, contrast media in the radiology department, and some antiseptics, and colloid IV fluids like starch, gelatin and dextran, and some dyes like methylene blue. So how will you recognize it? It is a life-threatening reaction. So it involves airway, breathing and circulation along with skin and mucosal changes. So airway, it causes hoarseness, uh, voice changes, and stridor, noisy breathing, and tongue lip swelling. In breathing, it causes wheeze, dyspnea, hypoxia and severe bronchospasm. And circulation, it causes hypotension, tachycardia and collapse. And skin, it causes flushing, redness, urticaria, urticarial rashes and angioedema. And angioedema, it just a swelling in the deep layers of the skin and other tissues, which will usually be accompanied with itchy and raised rashes all over the body, but it usually seen around the lips and the eyes. So anaphylaxis can be graded into four. Grade 1 usually involves skin. Grade 2 involves skin with mild symptoms which are not serious. Grade 3 involves life-threatening airway like bronchospasm and circulation issues like hypotension, tachycardia, and which is serious. And grade 4, it is cardiac or respiratory arrest. So what are the immediate actions? Immediate action, it is a medical emergency. So call for help and announce code blue, and stop suspected trigger. So whichever is the agent causing suspected to cause is causing anaphylaxis, stop it. Lay the patient flat, raise his legs, give 100% oxygen, monitor ECG, BP and SpO2. The first line drug is adrenaline, which is life-saving drug. So where it will be given? It will be given on mid anterolateral thigh. So the dose, adult dose, usually the adrenaline will be available in ampule. So 1 mg per ml in a concentration of 1:1000, which is standard. So for adult, we will give 0.5 ml IM. For children, 0.3 mg 6 to 12 years, 0.3 mg IM. and children less than 6 years 0.15 mg IM, and it will be repeated every 5 minutes. So when we will say the anaphylaxis is refractory, not responding, so after 2 IM doses of adrenaline given and the symptoms are not improving, then it is refractory anaphylaxis. How we will treat it? We will treat it by establishing an access, IV cannula. So IV fluid bolus will be given rapidly, 20 ml per kg, normal saline. And if it's still unresponsive, like hypotensive, then start IV adrenaline infusion 1 mg in 100 ml NS, that will come to 10 mcg microgram per ml. So under expert supervision, you can start at like 1 ml per hour and increase accordingly. So if the patient is on beta blockers and not even responding to adrenaline, you can add glucagon 1 to 2 mg IV. So what are the additional drugs along with adrenaline which will be given for anaphylaxis? Those are hydrocortisone 200 mg IV, chlorpheniramine 10 mg IV, salbutamol nebulization 2.5 to 5 mg. Why hydrocortisone given? So it will prevent biphasic reaction. Why? What do you mean by biphasic reaction? So when the patient had anaphylaxis and was treated and patient had recovered, but again after few hours there is a recurrence. To prevent that recurrence, hydrocortisone will be given. So chlorpheniramine is given to control urticaria and itching, which are the skin and mucosal like manifestations. Salbutamol nebulization will be given to relieve bronchospasm. So what we have to do after this is to monitor and observe. So we monitor ECG, blood pressure and SpO2 and document all the intervention we have given, and we have to observe the patient for minimum 6 to 12 hours, if severe 24 hours. Watch for any biphasic reaction or recurrences. So post crisis we have to like in the notes of the patient we have to write anaphylaxis for this suspected trigger, and the treatment given will be documented, and we will refer the patient for allergy testing after 4 to 6 weeks, and education the patient regarding avoiding the trigger for trigger or suspected agent for anaphylaxis, and use how to use the auto injector of adrenaline. So and we are a medical alert tag like regarding the suspected triggering agent. Thank you.